webinar. So we're going to have a very interesting topic. We're talking about healthcare financing. So it's a series of clinical governance conversations that we've been having, and today we're going to talk about financing. How do we finance clinical governance? I hope you've been following through the series. We had one session last month, and we hope to have another one before the end of the year, at least just to talk about clinical governance and what you need to know. So welcome to the session. We have three speakers today. We have Dr. Richard Kamau, who's a board of management member at Kenyatta National Hospital. We have Dr. Richard Aya, who's a senior lecturer at University of Nairobi, and has been quite a key person in our webinars, especially when it comes to issues of public health. We've had quite a number of conversations on COVID and many other public health measures with him, and we appreciate that he found time to come have a conversation with us today. Then we also have Dr. Job Makanga, who's the Director of Planning and Strategy at Kenyatta National Hospital. He'll be joining us in this conversation. Karibuni sana. Please remember to put your questions in the Q&A section and your comments in the chat box, or any sentiments that you share, you can put them in the Q&A section. So I'd like to request Dr. Richard Aya to start us off in this conversation so that we get a baseline. Then we have Dr. Richard Kamau taking us through a few areas of clinical governance, and then we'll finalize with Dr. Job Makanga. And also in our presence, we have our Senior Director Clinical Service, Dr. Irene Inwani. We appreciate that we're able to log in despite being busy, having a busy schedule. So Dr. Richard Aya, karibu sana.
Yeah, thank you very much, Rhoda, for that introduction. And thank you very much for inviting me to participate in this webinar series, and particularly this one around clinical governance, which is something that is close to me in the sense that it is part of what I teach in terms of health services management, and also done some studies around governance. So I thought after the discussion we had a couple of weeks ago, which I thought was really, really good, where we had Dr. Richard Kamau and his co-director, Dr. Nelson Bitonga from the board of KNH, coming to talk about the corporate governance and what they're doing at board level. And I think it was probably one of the few times that I've seen board members come to participate in events such as this. And I think one of the things that we need to look at is how we link what happens with practitioners with what happens at the corporate level. So in terms of thinking about clinical governance, I thought the remarks that I would make would be around that, just for us to have a discussion around that. And allow me to digress just one point, which is that we all know how health is structured and the issues that there have been in health in terms of once health was devolved. We have counties providing the care, but financing to a large extent has not been devolved in a similar fashion. The process of, at the national level, I'm talking about public financing, is still one of negotiation. It's a political process in terms of the budgeting. So we have a situation where when we get to the point now where we want to give out care, we set certain standards, but there seems to be a disconnect from my view in terms of how we link that political process. It's supposed to be accompanied by resources, and essentially that political process is about allocating funds, and the more technical side of things, which is the duty to care that the clinician will have to the patient. So how do we reconcile that? Those two things, one is a political process and one is a technical process, and ensure that the person who has to now deliver the care does not suffer, or worse still, the patient suffers. So that's the sort of context that I am looking at this in. So The issue about clinical governance, I mean, from the last discussion we had talked about the definition, and it's about accountability. So one of the really vexing questions is who is accountable for the patient? We know that by law, it's going to be, it's the medical officer who signs off the death certificate and also signs the birth certificate. So we know that that is the person who is responsible for the life. Now, if we have a situation where that person is unable to take care of that life, then who is accountable? Is it still the practitioner who should take responsibility, i.e., for example, if we're in a very a society that has a lot of litigation, like say the US, you end up suing the doctor, and therefore you have insurance costs that go out of control. And so that's one way of doing it. But there's so many other actors that are around. So should it be the board, for example, that takes responsibility when there is a patient, or should it be the CEO? And we see that once we move away from the board, because the board will have people who are nominated for various reasons. So we know that the way in which the board is structured, there are those representatives of the technical side, for example, the CEO, there are board members who represent the community, and then the board members were chosen for various backgrounds, perhaps in management and so on. So how much should they take in terms of accountability? How much should they be responsible in terms of accountability when it comes to the clinical side of things? So that for me is the first thing that we need to have some very clear guidelines and going into actual rules and regulations, so that when we set out clinical governance, as Dr. Inwani presented last time around, and we say this is a standard that we expect to achieve, then we know where the accountability lies. So if resources don't come, if, for example, we have not enough money, then we know who should be accountable. The next bit then is to talk about the support services. These range from those who set out strategy and lay out plans. And there's this statement that people like to make that, oh, we can write policies, but we don't know how to implement. For me, it's a policy failure when the implementation is poor. It means that we're not taking into account the context, which is what health systems management is all about. So we haven't really factored in the context properly, and we're doing pie in the sky and hoping that some miracle will happen. We shouldn't be doing that. So we should be planning for what is realistic and what is practical. Yet, when we think about the human life is one. And therefore, we have to think about what do we really value and make those explicit. So we have the support services all the way from the management into procurement and all the other allied services that come in. You would think from the food, the beds, the equipment, and so on. So how accountable should they be? So what role, when we think about the clinical governance, and we already said we know who is responsible for the life, what role should they play? Should a doctor be able to veto, or a nurse be able to veto and say, I don't want this bit of equipment because I think it's going to affect the patient care? And that should be the overriding thing. So we also need to have that discussion, and I'm glad that we're going to have the director planning and strategy to also talk a little bit about that, because I think they play a really important role. And I think it is an underappreciated role. And I think also there is elements of communication which we haven't done very well in terms of translating some of this clinical stuff into, say, procurement. So we have laws around procurement, for example, but there's some stuff that really needs to be tailored towards the clinical practice. So the third bit is one which, given the way there's been a lot of strife in human resource, is the role that the practitioner then plays in terms of clinical governance. So it's one thing to be able to say, okay, I've taken an oath to take care of the patient, but how far should I go? What happens when perhaps resources are not there, or the financing is not done correctly? When do I draw the line and I stop? So those for me, that's the context in which I'd look at this discussion. And then now I'll turn my attention to just talk a little bit about financing and in terms of what it is that we know. We know that at the national level, we have a very inadequate budget that goes to health. So that's a fact. And we have to realize that. The second thing is that we're torn in terms of our development priorities, in terms of what it is that we allocate to health. So we're conflicted in that. The third is that we're fairly inefficient and ineffective in the services that we offer. So there's lots of room for improvement. So the financing that we have is inadequate to begin with, and it's not very well utilized once whatever is available. So there's a question about how do we allocate the little financing that is available and who should be involved in that conversation. And what I'm hoping will happen out of these discussions is that we'll have a lot more realistic way of thinking about this so that we don't necessarily take wholesale clinical governance tenets that we are not able to implement. So we need to do a little bit of innovation around that. And finally, just before I hand over, I'd like to see a situation where the underpinnings of how we define clinical governance are based on the values of our society and not on other societies, which means that we need to have a discussion around what are the values, the moral standards that we hold as a society and implement those in our clinical governance structure. So thank you very much for listening to me.
Thank you, Dr. Richard Aya, for that, for opening up the session. Appreciate that. And you brought up very pertinent issues. You brought up the issue of public financing being a political issue, not health-related issue or an economic issue, but it's more of a political process. And issues of accountability, those are very pertinent sentiments that you brought up there. There's the issue of implementation of policy. People always say in Kenya, we have very good policy, especially in the Ministry of Health, we have very good policy development mechanisms, and you have very good documents. When you go to a facility, you find you have very good, but implementation is a challenge. And maybe at some point we'll just talk about or mention the universal healthcare coverage. There's a policy with regards to it, and we're supposed to implement it as in Kenya at the county level, at the national level, at all facility level. It's one of the things that we need to implement. In the commenting section, I'd like to ask the participants, just give your sentiments about the UHC, Universal Healthcare Coverage. How best can we implement it? There's a policy to it. I don't know if you're conversant with it, but what are your suggestions? What are your inputs? What do you think we can do as a country to implement some of these policies that we've developed? And you also brought up the issue that we play as practitioners in clinical governance. So thank you for that introduction. I'd like to move over to Dr. Richard Kamau, just to give us his thoughts on this conversation. And then now, Dr. Richard Kamau will have Dr. Job Makanga, then we'll open up the session. So Dr. Richard Kamau, karibu.
Thank you, Dr. Kalondu. Thank you very much. And much thanks to Dr. Aya for your very, very useful remarks on the issues of clinical governance in as far as health service management is concerned. And I'm looking forward to even more exchanges in this session when we hear from Job Makanga, whom I've had the privilege and opportunity to work with, and I know he's very astute when it comes to such issues. I want to see how he plugs himself in his remarks with the respect of financing clinical governance. Now, my remarks will be few. And the question is, or rather, the point I want to underscore is that there is no clinical governance without financing. Financing of clinical governance is an extension of financing healthcare. And why do we need funds for clinical governance. We need clinical governance because we need to employ people, we need to motivate people, and we need to take care of them when they fall sick or when they have misfortune. We need to acquire medicines, we need to acquire equipment, and we need to acquire health technologies. We need to promote patient and provider safety. And we need to conduct research, and we need to disseminate findings of those research. We need to train staff. We need to mount pharmacovigilance services to protect patients from the harm side of medicines. We require to maintain in good shape the health information management systems of hospitals. And we also need to regularly conduct clinical audits, and the list can go on. Clearly, we need to be financed for there to be meaningful clinical governance. And where do these funds come from? We all know our traditional sources of funding. Number one is the user fees. And user fees have got their own challenges. We know the other source is government funding from the exchequer. And we also know we have donor funding or from philanthropists. And maybe there could be one more. Somebody might help me if we were to extend that list. But those are the three I remember currently. Now, and what are the three key activities of corporate governance? Of clinical governance. Number one, in this respect, in terms of financing, clinical governance has a role that is in the periphery, but which is also very key to its activities. And I'll just mention three. One of them is revenue collection or generation. You know, in the process of giving services, clinical services, that process in itself is a process of revenue collection or generation. Once these revenues have been collected, they require to be pooled. They need to be put in a common basket where now I go to the third one, where efficient application of the funds for provision of services is done from. The challenge with the fund mobilization methods, like I've said, the user fees, the government, and the donor funding, is that when we come to the user fees, we are talking about underscoring the disconnect between the poor and the rich. In other words, when you put user fees there, you find that the people who are able financially are the ones who consume the services, and the people who are poor find it difficult to access the services. I look to a position where, and I know Kenya, we are getting there very slowly, where we get people paying for services when they are not sick. Indeed, that's the concept of health insurance or social health protection. When it comes to government funding, the amount of money we get from the exchequer will depend on the ability of the government to collect taxes. And when we come to donor funding, and also in the case of philanthropists, here we all know that this is a funding that is erratic, and you cannot rely on it, and you find it difficult even to plan for it. To conclude, let me put it this way. Corporate governance function requires to be funded for it to function. The funds must be applied efficiently and with integrity. And in doing this, it must be borne in mind that not everyone is able to pay, I've just pointed out. And a third-party financier has an important role in assisting clinical governance function of a well-running hospital and a well-running health institution. To wrap it up, there is no functional clinical governance without the requisite financing. Thank you.
Thank you very much, Dr. Richard Kamau, for that. And I agree with you, there is no clinical governance without financing. I like the way you brought out the issues of the WHO Health system building blocks. We talked about service delivery, the health workforce, information and research, medical products and technology, leadership and governance, and healthcare financing. You've also taken us through the various sources with which facilities get their money. And I don't know if there's anyone from hospital management team at the county level in this meeting. Maybe you can just share with us about the money that is generated at your facility. What % of it is plowed back from the county government back to your facility? You can, if you're free enough to share with us, you can just give us a rough %. Is it 10%, 5%, 20%, so that we're also able to know whether we are building back and giving back to the facility that is generating the revenue. I'd like now next to invite Dr. Job Makanga to take us through his sentiments about healthcare financing. Dr. Job is the Director of Planning and Strategy at KNH. So he'll be able to give us a really comprehensive picture of what it goes through in terms of planning and developing strategy for the hospital. Dr.
Okay.
Job Makanga.
Thank you very much, Dr. Kalondu. Very interesting indeed, listening to Dr. Aya, my senior there, Dr. Richard Kamau, my board member there, and of course, how you're bringing out and trying to link the ideas. Just picking up from Dr. Aya, it all starts with planning and strategy. And the biggest challenge of the entire cycle comes in at financing. Probably just to give us an overview, when we look at clinical governance, you note that in the context of healthcare systems, clinical governance becomes the heartbeat, because clinical governance has to deliver on all the components that we envisage in the entire service delivery chain. When we look at even the results matrix, and especially for us as we deliver services to the Kenyan citizens and others, you realize that the expectations are very high, and the so-called Wanjiku believes that you have the right capacity, the right funding that should be able to enable you give services without any hesitation or excuses whatsoever. However, when we look at our strategy cycle, you realize that in the end of it, where we have strategy governance and allocation of resources, you realize that the resources now become scarce. And the Abuja Declaration of where we had a recommendation of 15% provision of the national budget to the health sector. For us in the health sector in this country, we've not achieved, because if you look at the available funding, as Dr. Kamau has put it, the envelope keeps on shrinking, and the available funds oscillate between 5 to 7%. There are competing interests, especially based on our level of development of the health sector. Then it leaves organizations like KNH in a position that we may not be able to execute effectively on all our planned activities, and resource allocation becomes a challenge. And at that point, you realize that now the strategy is collapsing. And when a strategy collapses, it means the entire clinical governance is not working. When I look at what really absorbs the finances that are set aside for health, the biggest consumers, you look at health HR. Then of course, you look at the health commodities. And of course, now you crown it up with the health infrastructure. If these are not funded well, now you end up in the issues that we have in the health sector, industrial action, of course, unwarranted loss of life. And as Dr. Aya said, so who takes the blame? Is it the service provider, or is it the person who is responsible for giving finances, or is it the management of the hospital? So I think we'll be drawing correlations between these as we move forward. But my take home is health financing is very key for the success of clinical governance and for the success of any health sector strategy. Thank you, Rhoda.
Thank you very much. Thank you, Dr. Job Makanga, for that introduction. And I agree with you, human resource takes quite a big chunk of resources or the revenue that is allocated to a facility. It also, the medical products and infrastructure. healthcare is expensive, and the investment that goes into healthcare is quite tasky. If you buy just one equipment, you might find you spend quite a number of millions. So thank you for that, and thank you for that introduction. Now, before we go to discussing briefly about universal healthcare coverage, I'm seeing a few comments in the Q&A section, and I'll start with one from Dr. Lydia Kutai. She's saying universal healthcare coverage gives an opportunity to have the access to quality care with regards to protection against catastrophic expenditure for healthcare. How we select the minimal package and how incremental we make this is the big question. This should be underpinned on the needs of the population and ensuring equity is upheld across the age groups, disease condition, promotive and rehabilitative and curative services. And she's asking us to comment on challenges we face with regards to funding UHC. She also says that indeed, health financing is an important enabler for clinical governance to happen. What are the approaches of health financing that enabled progressiveness in better coverage for developing countries like ours? Thank you for that. Then Professor Lema is saying financing healthcare is a thorny issue all over the world. The question is how to quantify the services in monetary terms and apportion related costs to individual patients. How can this be addressed in both public and private health facilities? So this brings us to the next session of discussing universal healthcare coverage, which is, I won't say it's a project that the government has embarked on. It's a vision that we have as a country to provide accessible, affordable care to the citizens of this country. It's also part of what is in the Constitution. It's our mandate in the Constitution. So let's talk briefly about universal healthcare coverage and financing it. Now, we know there are challenges. Most of our patients have been paying from out of pocket. Most of Kenyans don't, very few percent have health insurance. Also, NHIF coverage has not been very adequate, especially in areas where most people are paying from, they're not employed. So how do we fund universal healthcare coverage? Now that universal healthcare coverage is something that has been rolled out and we are supposed to implement it. We did trials in a few counties. The feedback we got 2 months ago was that it didn't work out too well. Yet the policy itself on paper looks very good. The implementation, which is what Dr. Aya had tried to hint on, is a challenge. So Dr. Aya, a bit more about universal healthcare coverage, funding it, and how to ensure that our citizens or we ourselves get affordable and we're able to access care in our country. How do we go about it?
Thanks for that, and thanks for the comments from Dr. Kutai and Professor Lema. There is a short answer and a long answer about UHC. The short answer about UHC is that until our taxes double, we will not achieve UHC. So in health, we're on the side of, we're supposed to be the ones spending the tax that is collected. So in a way, even though many of us complain, we should be happy when care and government is able to collect taxes because we're spenders. We're not supposed to be ones generating the money. At the moment, this is at national level, the proportion of tax to GDP is about 18%, and it's been dropping with time. So we have a problem there. In developed countries, that figure is about 34–35%, and that's how they're able to achieve these social services such as health and education and so on for them to be free. As Dr. Kamau mentioned, stuff like user fees is extremely inefficient. It's also a form of a regressive tax because those who cannot afford and then have to pay out of pocket suffer more than those who are well off. So the ideal way to go is to go via a tax-financed health system. And to do that, we have to go beyond being able to just finance what are called the regal services, which is the police, the presidency, and just the basics, doing roads and so on. So health and education is somewhere in the middle. Health tends to come towards the end. In order to do that, we need to be in the 30% or so in terms of proportion of GDP. So we have some way to go. And I think the examples of countries that have achieved UHC in the recent past, it's taken between 1 and 2 generations. So the other bit about UHC is that it's a journey. We started off with maternal health. For a very long time, services for infants, immunization and so on have been free. So we've had some bits of the population that have been able to get coverage, but of course it's not universal. So it's going to take the 20, 40 years, and it's never been done at our level of GDP. Even countries that had gone further than us, like Ghana, sort of came back. I think Rwanda is the only example where they've done it on a fairly low per capita basis. So we have to be able to increase the total amount of money that is coming in. The second thing then is the money that comes in, how do we prioritize? We need to choose some groups. So already, children have been chosen, women have been chosen. We've had our HIV, TB has been covered to a large extent. So the big group that has not been covered are non-communicable diseases, and also like surgery and so on. Those have not been covered, a lot of inpatient costs, which is where KNH sits. So there's a challenge there if we rely on user fees. So we need to think about how that is to be done. The other point that I would make around this is we are sitting in a very bad place, which is that 25% of our health funding is donor funded. Since we became a middle income country, donor funding will disappear. And it starts disappearing from, I think, 2022, 2023. So the sort of free money we have been used to, on which all of us have sort of grown up on, is going to disappear. So what it means now moving forward is that health is going to have to borrow just like other sectors. So like, for example, the water sector are supposed to build dams, electricity, they're supposed to borrow money commercially or however they do it, and then show a return on money. So that poses a challenge for us when we think about stuff like clinical governance. How do we show, and that's one of the questions I think that Prof. Lema asked, how do we quantify the service and turn it into money so that we can justify borrowing money and saying that if we borrow this money to spend it on clinical governance or on patient services, then it will be repaid. And that starts from 2022-23 onwards. So we're going to have a real problem, and we need to start to have our thinking to change. That we're not going to have donor funding. We're not going to have the US government, for example, coming with donor funding for HIV care. So one of the big challenges moving forward, it starts off, for example, with financing HIV care. How are we going to do it come 2023-24, and when donor funding disappears? Thank you. I'll just pause there.
Okay, thank you for that. Thank you for that sentiment, Dr. Richard Kamau. Sorry, Dr. Richard Aya. I'm seeing Professor Omo Nzala. I don't know if he's dropped out, but he was here. And there's a time we're having a discussion about vaccine. And that is one of the services that we expect or is projected to suffer drastically from 2022-2023 once Gavi pulls out. It's one of the areas where we've been getting quite a lot of donor-funded support. And thank you for bringing that up, Dr. Richard Aya. It's true, it's a discussion, it's a conversation we need to start having. We've been relying very heavily on funding from other sources, not our own revenue generation or from the government, but from external funders. And if the classification that we got is going to change that, then we really need to think as an industry on how best to be able to provide adequate and quality, efficient, effective care to our patients. And we're also part of the population that will need that care. Let's not forget that we're part of that population. So let's have that conversation. So Dr. Richard Kamau, universal healthcare coverage. I know as a board of management, it's part of the things that is probably on the docket to be delivered in KNH, and Dr. Job Makanga has been part of the team that has been spearheading that. So I'd love to hear your sentiments about universal healthcare coverage. Maybe the 1 year experience, Dr. Job Makanga will be able to give us his experience in the last 1 year, how it has been like getting funding and also just getting the services and the projects running. So Dr. Richard Kamau.
Thank you, Dr. Kalondu. I wouldn't say much on the issue of financing of universal coverage. I'll leave that to Job. I know he's at the center of things. But having said that, I wish to speak of an abstract position, which in my view, if was politically accepted and if it was found technically sound, will probably bring us too close to being able to finance health services, clinical governance included. In this country, I would propose to have a situation where there is a clear strategy where young people support the old people in terms of their healthcare needs. I would like to see a clear strategy where rich people support the poor people. I would like to see a strategy where people who have jobs, people who are employed, are able to support those who are jobless in terms of their healthcare needs. And I would like to see a situation, a better situation of where people who are not sick support those who are sick. Currently, we have an element of that because the structure of the National Health Insurance Fund is such that we pay when we are not sick, so that the fund takes care of us when we get sick. We know its successes, we know its weaknesses, and therefore, if we go on like that and include other strategies of getting this money, perhaps we'll get to a situation where we are close to the 15% of national budget. We, in accordance with the Abuja Declaration of 2001, where governments were urged to allocate 15% of their budgets to healthcare. Currently, I think we are very low. I don't have the percent. I know Job has it in his head, but we are very, very far. And our goal should be to get very close to 15%, because it is estimated that if we are able to get there, then we will have no problem rolling out the universal health care. Thank you.
Thank you. Thank you, Dr. Richard Kamau. Dr. Job Makanga?
Yes, thank you, Dr. Aya and Dr. Kamau. Picking up from the discussions therein, first, as a country, we are far much. We are about a third way. We are oscillating between 5% and 7%. And with the issues that we had, so we're just looking at 7% as a current funding by GOK to health, which is far much below the expectation. And probably this could explain why we have challenges. However, the initiatives that are aboard are bearing fruit. When we look at the 4 pilot counties for UHC, we note that access increased. Of course, affordability was cushioned by government because the Kenyans were vulnerable and were accessing services were not paying. And from where we sit, we hope and believe that the quality was not compromised. Now, the cost of rolling out this nationwide is where there's a big challenge. And the government is really working around the clock. You saw the other day when the president was in Mombasa, rolling out now this to see how NHIF, with the reforms that have been done, can run with this so that we are anchoring UHC to a kind of a social health insurance fund. And this fund, for it to succeed, as Dr. Kamau has said, it must be seriously contributory so that the people in the society who can afford should be able to put in more so that we're able to cushion our brothers and sisters who are vulnerable. And when this happens, from the projections, we should be able in the next 2-3 years to at least comfortably say that we've covered half of the households, about 6 million households, through for basic and some level of care. And I like what Dr. Aya has alluded to. Studies in countries that have achieved in US have clearly revealed that achievement and successful achievement is multi-generational, such that it rolls over and it also goes with the culture of the nation. because even the culture of putting resources together from an individual perspective is something that needs to be nurtured across board so that we are able to see how we put our resources. Otherwise, we'll have a challenge in realizing UHC because the biggest component of the success of UHC is funding. And this funding has to go all the way to support the infrastructure. We are talking about, in the fullness of time, that no Kenyan citizen should be able to move beyond 1 kilometer to access healthcare. For this to happen, it means we have also to introduce new facilities. We have to increase the number of health HR, the health workforce. The distribution channel for the health commodities has to be enhanced. But this one takes us, the two of us, all of us to really put our heads together. We really need a lot of input from the county governments, health being a devolved function, such that in the prioritization of resources, especially for infrastructure, we are able to see a lot of infrastructure also going in terms of healthcare, some funds being put aside to enable have access to health commodities. And I believe if we move in this direction and we are able to support this wholly, we should be able to start realizing the fruits of UHC. Already, there's what we call the conditional grants to level 5 and some level 4s as a part of just cushioning the hospitals for the loss of user fee as a result of implementing UHC. This has taken root and the government has prioritized it. If this happens and we are able to take this to all levels of hospitals, then we are as well guarantee that whenever citizens seeking care visit these facilities are able to get treatment, then we'll be making milestones in UHC. So largely for us to succeed in this financing of healthcare and achieve our milestones in clinical governance, the government has to really increase the funding allocation to health so that this agenda is successful. When I even look at the Big Four agenda, honestly, the rest of the Big Four agenda is incumbent on this health because you cannot have manufacturing succeeding when you don't have a healthy nation. So probably we'll need to, as we pursue the 4 agenda items, probably in terms of priority, we need to see how do we give more funds to health sector, probably push it to 10%. And this is possible if there's a lot of stakeholder involvement. We are in the new cycle of budget preparation. The sector working groups are going on. After this, we'll have what we call public participation. This will be a very good opportunity for stakeholders, as we are doing now, probably to come up with a memoranda to present as a petition more resources to be allocated to the health sector to move it from 7% to probably 10% with the interest of UHC and reaching out to the population that cannot afford care. Thank you very much.
Okay, thank you very much, Dr. Joe Makanga, for that, and thank you for bringing out the issues of funding and quality, issues of out-of-pocket spending. And when you talk about quality, the things that we're looking at, was it safe care? Was it timely? Was it efficient? Was it effective? And was it person-centered care? So as we fund our institutions, as we fund healthcare, those are some of the things that we need to look at. And this brings me to the next question about disparities between funding in private sector and public sector. Maybe this is a personal observation, it's not research or documented material, but in my opinion, I would say that the private sector invests quite a lot in their facilities, in the health facilities, the private hospitals, compared to the amount of investment that is put in back by the public sector. And this has a direct relation to the quality of care that you will receive if you walk into Aga Khan, if you walk into the Nairobi Hospital, if you walk into all these other facilities that are around, any private facility that is in your county. The service that you receive there is slightly different, according to the customer perception, from what you'll get at the public sector. So my question is, why is it that in the public sector, and I know this will be mostly based on your personal opinions, why mostly do we feel that we don't need to invest that much? Because the facility will generate revenue. They will give it to the county government or to the national government, but the amount of that revenue that is brought or plowed back in is only a small fraction. So you end up using the same equipment that you've been using for so long, yet the facility budgeted for it. If you send a budget, it ends up getting slashed. And we're looking more at the output. What output are you giving out? We're not looking at the outcomes that the care you're providing is giving out. Maybe the patients are walking home happier. We're just focusing so much on the numbers and the output. So why is it that in public sector, we feel that we really don't need to invest that much, or the facility will somehow survive with the little that you've given them? Dr. Job Makanga, maybe you can start us off with this, because I know you've been very active in the budget negotiation process. So you can just take us through this.
Yeah, thank you very much, Dr. Kalondu. First, I'll look at, I respond to your question on disparities in financing for private sector and public sector. When you look at the levels of input in terms of resources to really transform the private sector, indeed is high. But again, when you look at the cost of care that is being translated to the patient, it is not comparable to what is happening in the public sector. If the public sector was to employ the same pricing strategy as it is in the private sector, then we'll even be in a worse position in terms of access. However, all said, we are looking at two different parameters in terms of investment and funding. One is government dependent. And if I talk about, for example, KNH, in fact, all the funds we get as user fee, we just plow it back. This is what we used now to ensure that the services are running, operations and maintenance, the food for the patients, the medicines, and all that, because what we get from GOK in terms of recurrent is for payroll only, and is actually not sufficient to cater for the entire payroll. So again, we have to plug in something to top up on payroll. Then you realize that now even this money is not enough. When you look at our financial statements as a hospital, for example, you realize that we are continually operating on deficits because what we are collecting cannot sustain the level of operation. So we will continue striving to get a partner supporting us in certain areas to just ensure sustainability of service delivery, as well as see how well we can tweak, even with the user fee, to ensure that we are not losing so much in terms of what is expected as a user fee. So when you look at all those underpinnings, you realize that the challenges are real in public sector, and it's worse off at the county level because even affordability to that effect of having been able to afford the user fee is even actually dwindling as you go down the levels of community. So I want to probably discount the fact that they're collecting and transferring money to the national government. I don't think that is true, because facilities only take the money to the county government for purposes of now looking at their total collection, the recurrent, and how to top up, so that they're able to effectively also meet their budget shortfalls. So indeed, as a growing country, we really need a lot of support. And as you see, there's a lot of partner pull-out in terms of donor. Now that makes the situation worse. So what is the way forward? Probably that will be the question we're asking now. For us to succeed, what are the other proposals we need to put on the table? Of course, the easiest one will be to translate the cost of care to Wanjiku. But again, this is where we are trying to move away from, because Wanjiku cannot afford. Again, as a hospital, for us as KNH, we realize that we spend bills of up to 1 billion on indigents. People cannot afford, they cannot pay, they won't pay. So we have to treat clinical discharge, but upon final discharge, they can't afford, we have to let them go. So how do we mitigate this gap? Probably this is what we need to be looking at. Is there a way we can do to probably, as we are talking about the health sector, to see how we can spur the economy to provide opportunities for most of these Kenyans who cannot afford, so that now they can be able to meet the basic requirements of their life. and day to day. Because again, transferring the whole of this burden to government, which relies entirely on taxes, and we know you can only collect so much, leaves us in a catch-22 situation. Thank you very much.
Okay, thank you very much. Dr. Richard Aya, would you like to give us an input on that? And I also agree with Dr. Job Makanga on what he's talked about. The pricing strategy for the private and the public sector be very different. The cost of care is very high in private sector. Dr. Richard Aya, would you like to give an input into that?
Yeah, thanks, Dr. Ada. You said these were your own observations, but they're actually anchored in the data that we have. The private sector consumes about 50% of all the healthcare financing money that's available in Kenya, but they only contribute about 11% of care. So there's a lot of inequity in terms of, and that's why you see the investment that is there in the private sector, in the private hospitals. So there is a problem within the wider problem of scarcity of the total amount of money, that a lot of the money that is there goes to the private sector. Now, you'd allow me just to be a little controversial and give what I think is one of the problems that we have. There is a study done in the US that looked at how roads end up dividing people socially. And they looked at, just by building a road, you have one neighborhood on one side that is poor. This was sort of looking at, say, Black neighborhoods and ghettos and so on. And on the other side, you have a rich neighborhood with all the amenities. The road that I'm talking about is Ngong Road. And so you have Nairobi Hospital on one side, and you have Kenyatta Hospital on the other side. Now, before independence, this was really one system. And Kenyatta Hospital was for the natives, with a bit of Rantula for the Asians, and Nairobi Hospital was for the whites. Now, we all aspire to be in private care. And what we're building on is a legacy essentially of apartheid or colonialism as we look at it. So we're entrenching a system that is inherently inequitable and aspiring. I mean, I don't want to be like what Job is talking about, being one of the indigents who you can't afford to have. I'd rather be somebody who can afford. But when we talk about universal healthcare, we're talking about affordable care for everyone. I should ideally, I should not have a problem going to my local county or sub-county hospital. It should be equipped. After all, the doctor who is there is somebody who we trained in our medical school, so we know that they're capable of. So there are one of the big issues then around that is around the financing, and it's also around the clinical governance. How do I know that when I go to a small public facility that it has the standard of care that I think I should receive? So we have a fundamental problem that I think we need to just reflect on, and that is we're building on we've not discarded our history of colonialism. And so we continue to want to be private. So we look for private solutions to what essentially are public problems. So the moment you can, you opt out and you decide that there is a private solution. But health is a situation where it really is a public issue. So I think one of the things that we need to think about is how we engage our own government and policymakers who are not in health to get that understanding that opting out, not investing in our public facilities just cannot work. We have to invest in our public facilities. So my wish, and I wrote about this early on in COVID, would be that KNH really should be where the presidential ward is. So that if any of our very senior people in society fall ill, the first point to go into should be our main referral hospital, whichever one of our referral hospitals it is. So I'd love to see our strategy for KNH, and in it, there is to build a presidential ward, not that we're wishing the president, but even just for checkups, for example. The idea that we would have our president or any of our senior people go into a private hospital for care, which is owned by somebody making a profit, whoever it is, just doesn't make sense. You don't, the president, for example, is not guarded by a private security firm. He's guarded by our own public service, and it works. So why doesn't it work in health? So I think that's what we need to be thinking about in terms of equity, that we need to be investing in our public facility. And I think it is a mindset, and it is one that we should not be thinking about opting out. We should not be thinking, for example, that what I want as a medical practitioner is health insurance so that I can not go to KNH, for example. It should be the other way around, you know, that I have a UHC that as a health worker, I can go into care, and I know that care will be very good. Thank you.
Thank you very much, Dr. Richard Aya, for bringing out those sentiments. And right now, where we have an increase in the number of unemployed Kenyans, we have a lot of economic distress. We're finding that we have an increase in the public health, in demand for public health services. So I agree with you. We need to invest. We need to plow back quite a lot into the public health. I'm seeing Professor Omo Anzala is here with us and has raised his hand. So I'd like to ask KNH Resource Center, please give Dr. Omo Anzala the opportunity to make a comment. And we also have Dr. Victor Njong in the panel, and they'll be able to give us his experience at Kenyatta University Teaching and Referral Hospital. So Dr. Omo Anzala.
Yeah, thank you, so much. This has been a good discussion. And what I'd like just to request the panelists to discuss on is waste in the public sector. When COVID started, we realized that there was a major reduction in patients coming through. And even when we looked at the data at the National Health Insurance, there was also very few claims. So the issue is that what happened? And I'd actually asked Aya at one time, I think we discussed that we should look in that issue of medical, just waste in terms of resources. So I'd like to hear the three discuss this issue of waste. Then the second one is the issue of dependency culture. Dependency culture, we have now learned, is not going to take us anywhere. So the issue is that health was devolved, but there's nothing in the counties. So even if you look at Nairobi itself, people who are meant to go to the county hospitals in Nairobi all end up in KNH. So as we discuss this, how do we ensure that as we develop health, we are also devolving quality health in the sense that we don't all have to come to Kenyatta. I can go to Mama Lucy, I can go to Bagathi, but everything ends up at Kenyatta. And that's why Kenyatta is at this level. I'm sure some of you were in Mombasa not too long ago when universal healthcare was being discussed. Can I hear from the three discussants, what did you pick from there that is going to move us away from this dependency culture? And the second thing about waste, in terms of how much we waste, in terms of resources, so that at the end of the day, we cannot even afford the healthcare we should afford. Thank you.
Thank you very much, Professor Omo Anzala. My apologies, I referred to you roughly, Professor Omo Anzala. Thank you very much for that for your sentiments. Dr. Richard Aya, would you like to take us through waste in the public sector before we go to Dr. Richard Kamau and Dr. Job Makanga?
I think when COVID came, the term waste perhaps is a strong one. I think the public sector has a lot of challenges, and there's I think the more technical word I used would be the level of effectiveness is quite low. So one thing we know now, and especially out of COVID, is that the public health sector side of things is very weak. And there hasn't been a lot of investment in that. So that a lot of things that end up on the clinical side really are things that could have been sorted out by investment in public health. And I think that's why when COVID came up, a lot of cases melt away, because a lot of those things are things that can be sorted out much earlier. And so that's one thing. I think there's a lot of resource that is not utilized properly, especially our human resource, all the way up to doctors as well. So you'll find that a lot of doctors do complain about overwork. But I think a lot of it is to do with the fact that it's not efficient to begin with. So people spend a lot of time waiting around, for example, for something to happen, simply because A is not there or B is not there. So it looks like people are working a lot, but actually it could have been done in a much shorter period of time. So I cross and remember that there is a hospital care which is business, shall we say. So a lot of that melted away and it's hard to build up again. The other comment was around I think it was around NHIF and universal. Was it around universal healthcare and NHIF? I didn't quite get that point.
You know, the whole issue of NHIF, the fact that during COVID, there was massive reduction in claims. So you wonder what were these claims that were there before that didn't come through during COVID. And that's where we should begin to discuss about what you're talking about, efficiency and the proper use of resources so that we can actually afford the healthcare and move away from what I'm hearing about donors and this issue of dependency culture.
Okay, yeah. So let's just recap what NHIF is. So NHIF is a private members club. So it's originally for public servants or civil servants who are contributing essentially to access and be able to pay for healthcare because the public healthcare system was starting to collapse in the late 60s and 70s. So it was for middle management and senior civil servants to be able to access care and eventually to access care in the private sector. So much of the money that NHIF spends goes to private healthcare. So it's been one of the major challenges in trying to transform NHIF into a universal health coverage vehicle in terms of financing is that its origin was that it was meant for public servants to go to private hospitals. So even public hospitals have a challenge in terms of the way they finance to be able to access NHIF money because they're just not confident to do it. So we did some work at NHIF about 5-6 years ago, and one of the things was that perhaps we needed to look at another vehicle and not that one because it's just so entrenched in the way that it operates and its history and its legacy. So it would require literally very strong political will to transform it, and it has its owners who are the members who have been contributing towards it. So you have to somehow get rid of those people in that. So that's why when the moment that people stopped being admitted, NHIF claims went down because the people are obviously at home and it is paying for curative care. And a lot of it is, how shall we say, NHIF is running private hospitals. I mean, it's paying for private hospitals. So the moment private hospitals stop offering care, of course, NHIF would have no claims. And I think we have to be careful about relating NHIF and what it pays for and universal health coverage. Thanks.
Okay, thank you very much, Dr. Richard, for that. Dr. Job Makanga, would you like to make a comment about waste in public sector and dependency culture?
Yeah, sure, Dr.
Before Job comes in, can I come in on with a remark or two, Doc?
Yes, Dr. Richard Kamal, you can come in.
Yes, I wanted to come in at this point so that I don't forget the points that have come in my mind. Number one, we were talking about the pricing structure of our services. And as we discuss this, I would like to draw the attention of the participants. Like in Kenya, we have like three sectors in health sector. The first sector is the public sector. That's where we belong as KNH and the county hospitals. And then we have the faith-based organizations, or the faith, that's what we normally call the mission hospitals. And then finally we have the private for-profit organizations. Now these three, the way they price their services is very different. If you take, for example, the public sector, we only charge a nominal fee. We are not even allowed to charge the full fee of the service. we expect that the government will come in and make up for the difference so that we are able to raise enough money to run the services. But we are not allowed to do that. Yet the government, a lot of time, is not able to fill the gap that is created by us not charging the full fee. And there lies the issues of financing that we are talked about. Now, when it comes to faith-based organization, their pricing structure factors in external support. A lot of faith-based organizations get funding from outside, either from national NGOs or international NGOs, or the church itself, which is affiliated with the mission hospital. And therefore, they can afford to lower their prices a little less than the private for-profit hospitals, because they get external support. When they come to private for-profit hospitals, then they charge a full fee, including a profit element. That's why they are private for-profit organizations. And therefore, and this is to answer Dr. Kalondu, when you talked about the level of investment, they can afford to invest more money, whether it is a profit that has been plowed back or whether they take loans to finance those investments, knowing very well they will be able to pay the loans and be able to continue making profit from the services they offer. That's how we differ, and that's why even the level of service you will get from a private hospital will be a bit on higher, quality, because the money, when used efficiently, the more the investment, the better the quality of the service. Now, having said that, let me come to the issue of Dr. Omwanzala. I don't know whether he can remember me, but one time we sat together at Chiromo. He talked about waste in the public sector. Now, I will only say something very small with regard to waste, because from where I sit, I see waste as a consequence of poor resource allocation and poor supervision of resource utilization. Because the supervision is poor, people use the money poorly, and therefore the efficiency comes down, and we don't get the full value of the money that has been allocated. You also talked about why is it that everybody in Nairobi and if its environs wants to come to Kenyatta National Hospital. There are a number of reasons. I will just cite the one which come into mind right away. And the number one reason, and which has been a problem for us at KNH for many years, is the fact that the county hospitals, the Nairobi county hospitals, and the hospitals within the counties surrounding Nairobi do not function optimally. We have had cases of people going to Mama Lucy, for example, in the past, and Mama Lucy does not even operate at night. They close. I don't know whether they open at night anymore. And those people, it's the watchman who refers them to Kenyatta National Hospital. So we are suffering the inefficiency of the surrounding health institutions around us. That's one reason. The other reason, I would say, we suffer from our own success. You go out there, and when there's an issue, a health issue that has come up, whether it's a motor accident or whether it's an infectious disease, the first brand that comes into mind in many people, where they think they are going to get good service, is Kenyatta National Hospital. A lot can be said about our hospitals, a lot of it negative, but I can tell you down there on the ground, Kenyatta National Hospital is a brand. When they see those blue colors, they associate those blue brand colors with better services. So in a way, we suffer from our own success with regard to our brand image. And of course, they know that the kind of fees they are going to pay at Kenyatta National Hospital is not anywhere compared to what they would pay in a mission hospital or even in a private hospital. Now let me come to the issue of COVID, Dr. Omwanzala. You talked about the claims coming down. They are, I wouldn't say this is from studies that have been done, but we know of good reasons why the claims would come down around that time. Number one, you remember around that time there were lockdowns, which means that there are not many vehicles on the road, and above all, the public vehicles, which constitute a lot of accidents in this country, were not moving. And therefore, you will get the number of accidents on the road coming down. And with them coming down, of course, you had expected that the claims would come down, assuming those people had an HIF card. The other one, you remember the eateries and the bars were also closed. This means that a lot of foodborne diseases were curtailed, and therefore we don't get people coming to hospitals because of what they ate or what they drank. And of course, you know, those accidents also came down a lot because there was very little drunkenness on the road. Also, because of wearing masks to prevent COVID, the act of wearing that mask also prevented very many infectious diseases that are respiratory in nature. Daktari, I know this is a story you would be telling me, not the other way around. And therefore, personally, as a public health practitioner, around April, I wanted to see what will happen around June, July, when we enter our flu season in Kenya. Because around that time, you know, every other person you meet is coughing, it's blowing his nose, he's running nose, he's running a flu, which of course in the past would just take it like a passing cloud, and indeed it was. But in this particular case, I feared the confusion that will come when people get our normal flu in the midst of COVID. But it didn't happen. Even up to now, I realized that our normal flu season passed. Not many people coughed. Not many people had running nose and so on. And therefore, if there was going to be an infection of that nature that makes people go to hospital and get hospitalized, of course, we know a section of our society reaches that point. Then, of course, the number of claims for from NHIF would come down. And of course, there was also the number of people coming to hospitals coming down because people feared going to hospital and maybe getting mixed up with the people who have COVID. And finally, there's also something in insurance they call it moral hazard. Moral hazard is defined as that opportunity that has been provided for you to access healthcare, and you end up wanting to access healthcare even when you don't need it, simply because you have a card, simply because you are covered. It encourages you to consume that service. Now, within the COVID environment, even moral hazard was not in play, simply because people did not want to go and mix with other people who are sick, lest they get the COVID. Thank you.
Thank you very much, Dr. Richard Kamau. And as you mentioned about the blue colors being associated with excellence and quality, I'd like to remind the participants that we have the CEO of our latest newest competitor, Kenyatta University Teaching and Referral Research Hospital, Dr. Victor Njom, whom I'd love to make a comment just after Dr. Job Makanga makes his comment about waste in the public sector and dependence culture. So Dr. Victor Njom, I'd like you to make a comment on waste just after Dr. Job Makanga makes his comment. Dr. Job Makanga?
Yes, thanks, Dr. Kalondu. Interesting. I've been also running through these discussions as we handle it. Seemingly, we are not getting to the bottom of financing per se. And Dr. Omwanzara turns me to the point, if we are not able to increase our resource envelope, so what are we doing with the current resources that we have? That's where the concept of wastage comes in. And I want to talk to wastage from about 3 or 4 parameters. One, I'll look at it from the claims, NHIF claims, but this time from a different perspective where we've had cases of claims coming in of even processes or procedures that probably hadn't been done, and largely from the private sector entities. And you will note that this has been in the public domain, and probably we need to find a way, how do we streamline the process flow in terms of claims, so that we are only paying what is value for money. Because when you look at the results matrix, where you have a constraint of resources, then you go back and say, fine, what do I do with the resources I have, with the inputs to maximize outputs and of course, optimize outcomes? And probably this is where we need to take this discussion back, look at our claims. Are we getting value for money? And what kind of processes or systems? I know there have been reforms and certain key changes at the NHIF towards the same. So we want to see, will this take us in the right direction such that within the existing basket, we are able to have a bigger outreach. Two, cost of procurement of goods and services. Are we really getting the best deal, especially when we are having and enjoying economies of scale? We had counties complaining that it's expensive to get goods from KEMSA. I think as health sector stakeholders, if we realize that these are issues that are really affecting delivery and affecting health financing in terms of optimizing the resource that's available, probably at this point, we need to come up with some policy change proposals. Must we compel people to buy from KEMSA when there are alternative sources of procurement? Ideally, the concept of KEMSA was to enjoy economies of scale and guarantee supply of these commodities, health commodities, at the lowest possible price. But is that what is happening? And again, that's where we talk about wastage, because if we're able to get this at a higher resource, at a higher cost than what we would ordinarily get, then what's the value addition to the entire service delivery chain? I'll also be talking to another very controversial point that of course my colleagues don't like hearing, but we need to address it candidly, because even when we talk about Mama Lucy, we are revolving around the same thing, wastage in the human resource time. Because human resource as a major input, as I alluded earlier, takes a bigger chunk of the health finance. Are we getting optimal results? Are we getting the desired outputs? When Mama Lucy closes shop and tells a watchman that these guys have to go to Kenyatta, and these people are enjoying government financing, they're on a government payroll, what mitigation measures are we putting in? What policy changes are we trying to put in to strengthen and even reinforce the referral strategy so that we are able to see value for money even down there? We are able to feel the outputs of the government investment in the human resource therein. COVID has also taught us a lot that indeed we can have cheaper locally produced goods. We've been able to produce masks because of the global closure of the boundaries and the airspaces. And again, this tells us probably the cartels in the health sector supply are the ones suffocating the local business people. So what kind of, again, policy indications can we put aboard to drive such that some of these commodities can be bought locally? I know we have Buy Kenya, Build Kenya, but how do we enforce this? Because now we are back to the same basket, because we may aspire to have a bigger basket of financing, but unless we are demonstrating effectiveness and efficiency in utilization of the available resource, then even the bigger resource may not be well utilized. And of course, finally, we'll be looking at how do we strengthen monitoring and evaluation across the health sector systems so that these wastages are not there and additional value is gotten by Mwananchi. Thank you.
Thank you very much, Dr. John Makanga, for those sentiments. Dr. Victor John?
Thank you very much, Rhoda. I agree with a lot of things which Job Makanga has said. First of all, maybe let me just say hi to Dr. Richard Aya. It's been a long time. We were together many, many years ago. I'm not entirely sure whether he can remember our interactions prior.
Of course I can.
Okay.
It's good to hear, and I've been following you as well.
Oh, thank you so much, Dr. Aya.
Right, yeah.
Yeah. So my comment about it's mainly to give the experience of KU teaching and referral hospital. We are lucky that we are a new institution, and therefore you can come in with a new organizational culture and a new way of doing things. So one of the main things which you have done is to strictly enforce the referral systems, so that you find that when you come to the institution, you only find a few patients who require tertiary level care. And maybe that has helped in reducing the bulk and the workload in the institution. The patients who come in mainly as elective cases, we have had very few challenges with regards to payment, because I guess they have time to prepare themselves for the expenses which come with the medical care. The challenge which we have had mainly are with the emergency cases, the RTAs and the emergency cases. We have had incidences where people are given care, and after treatment, payment becomes a challenge. The COVID situation, with the public pronouncement that COVID care is free, has also brought us some challenges. ICU care is very expensive. So we have tried as much as possible to ensure that we have a very, very strict waiver criteria. We don't tolerate a lot of the requests from third parties that, oh, I know who and who, so can this patient be released? So we've tried to maximize on our income from patients to ensure sustainability. But more importantly, we have been thinking of other ways of generating income rather than depending on user fees. And part of the mandate of this institution is to participate in research. And we actually have a strong directorate which is dealing with the research. We have people who are writing grants so that we can get grants from other facilities, so that we use that research and grants area to generate income, to try to ensure boosts the income which is got from the clinical area. We also have partnerships directorate, which is important in trying to link up with other parties to try to improve or sustain or boost the resources or finances which we get from other areas. So in summary, that is the situation with the KUTRRH. We depend a lot on government funding. And we were with Makanga recently trying to struggle for the meager resources in government. But we hope as an institution that within maybe 3 to next 5 years, we'll be entirely self-sustaining with the kind of other resources which we will get. In terms of patient costing of patient care, of course, we are sort of limited, being a government facility, to try to ensure that our prices are within reasonable limits so that we don't minimize access. But we're also thinking of a model of having a private component within the hospital, so that if there are patients who can afford the private level of care, I mean private, and when I mean level of care, I don't mean the medical aspects, I mean the hospitality aspects. Because if you come to our institution, you realize that the hospitality infrastructure is at the level of, if not better than most of the private hospitals in the country. So we can take advantage of that and develop a private model where the hospitality aspects are taken care of, but the medical aspects remain the same. The clinicians who are seeing the general patients will be the same ones who are seeing the private patients, and there'll be no preference in terms of medical care. But the hospitality care will be different. You know, the room, do you have a TV, hot water, what kind of meals you choose from a menu, and all that kind. And therefore that we hope also will boost the revenue. So Dr. Kalondu, that is basically my contribution. As an institution, we hope that KUTRRH in the next 3 to 5 years will be self-sustaining. If we can get to a level where only the recurrent in terms of personal emoluments are the ones which are handled by government. We hope that with all those measures which are put in place, we'll be able to self-sustain. Thank you very much.
Thank you, Dr. Victor Njom. And I like your vision that in the next 5 years you'll be self-sustaining. That would be really great to see. And we hope to continue learning and partnering more with you and collaborating more on these issues of healthcare. I like the fact that you started on a clean slate and you're able to implement some of the things like the referral system, which has been quite a challenge for us in Kenyatta, here at Kenyatta National Hospital, where we are having people walking in without proper referral systems being followed through. So continue with that in that same spirit. And that would be great to see. Also, the private model, that would be a very good, more like amenity, I presume. That would be a very good model to help improve on that. So participants, I'd like to thank all of you. And just before we end this session, I'd like the panelists to just make one final last comment. Remember our topic today, we were talking about healthcare financing, and our aim was to talk about how we can raise adequate funds for health so that we protect ourselves. We also put ourselves in this shoe. You might have your NHIF right now, you might have your private insurance cover, but we never know the future. So that we also protect ourselves from out-of-pocket spending and from catastrophic spending of finances into supporting and paying for services that should be a social service, but is not yet a social service. So we'll start with Dr. Richard Aya, Dr. Richard Kamau, and then we'll go to Dr. Job Makanga, just to give us the final remarks as we come to the end of the session.
Thank you very much for that. I think the remark that I would make is that when we're talking about clinical governance, we have to have one standard of care, which is the standard of care that is acceptable for the patient, irrespective of whether they can afford or not. And that's what we should be working towards. How can we finance a clinical governance structure that is able to meet the standard that we set? And one aspect that I think we didn't talk about too much, but I think will come up later on, is when we don't have this, then it's the clinician who has to face the patient who suffers. That is the mental stress and so on. And I'll finish off just with an anecdote. Many years ago, I was invited to South Africa to do a consultancy around health financing and private care. And the reason I was invited was because I'd just left KNH. And what they were interested in was, because I have a background in health financing, what they're interested in was this idea that you have a private wing inside a public hospital. So I went to make a presentation in one of the provincial assemblies, and they had all their legislators there. And so they were interviewing us for this consulting work. And the question they were asking is that, so what you're saying is that you have a private hospital inside a public hospital? And I'd say yes. And they'd stop and look at each other and say, but it's a public hospital owned by the government. I said yes. Owned by the people, yes. But you're saying that in that you have a private facility where you charge differently. And I'd pause and say yes. By the time we finished the discussion and we went away, they just could not understand how that was possible. And I think that's one thing that we need to think about, which is when something already is public, why again do we have private inside? Thank you.
Thank you for that. Dr. Richard Kamau.
Oh, thank you. I think those are very good remarks that were made. I make my remarks and respond or perhaps add to what Dr. Victor Njom has said. The hospital, the QRTH, Dr. I can tell you, you need to be on your toes because I don't live very far from there, and I know you are fast gaining a very, very good reputation. Your hospital becomes very reputable, and it won't take long, in my estimation, before you start suffering from your own success like KNH has. You also have another advantage, which as KNH we don't have, because you are very accessible from central Kenya. The physical accessibility also adds on to your popularity. And I want to believe you'll put structures and strategies in place to ensure that you remain referral, because that's one of our biggest challenge that we are unable to shed off at KNH. Having said that, let me also add this, that financing clinical services is not the same as financing clinical governance. We need to now start to be awake so that when we do our finances, when we do our financial planning, we are clear when we are financing clinical services and when we are funding that component of clinical governance, so that the governance element is not disabled or made made not to work simply because there is not that component that goes into the governance part. So thank you.
Thank you, Dr. Richard Kamau. Dr. Job Makanga.
Yes, thank you. Thank you, Dr. Kamau and Dr. Aya. And of course, thank you, Dr. Kalondu. I'll speak to my closing remarks in terms of where I sit and where I come from, that the whole circle of what we are talking about in terms of clinical governance financing, UHC, I put it in the context of the strategy cycle, as I alluded earlier, that in terms of strategic formulation of where we want to go, we are very clear, even as a nation, as a sector. In terms of strategic transformation, where now we are supposed to really put, align the operational model to speak to our strategic focus, which in this case is the accessibility, affordability, and of course, quality of healthcare. And of course, inside there, coupled with financing. Now that alignment is where the rain starts beating us, and it even affects the strategy execution, where we are not able to deliver to our value propositions in terms of are we reaching out? And when we move further, you realize that the other part that the rain is beating us is in terms of strategy engagement. Have we really spread the net wide in terms of getting stakeholder engagement, speaking to them to buy in terms of our direction of as a health sector, in terms of where we want to go in terms of financing? Have we really reached out to the key players, the stakeholders? Why are they keen in financing? Probably talk about the private sector as opposed to the public sector. Of course, the philanthropist, have we really gotten good of all the philanthropists, the partners, in terms of engagement? And once those are not achieved, we get stuck at what we call strategy governance, because we will not have the resources, we will not get the processes we wanted in place. The risk management, the risks that we've identified earlier there in terms of even what are the risks of clinical governance, they come to mature. You realize that you are not able to achieve, you're not able to even attain 50% of the activities you plan because largely you lack the resources to do the same. Then of course, that translates into quality assurance, because now the outputs and the outcomes are not meeting the desired threshold. So for us, I think we need to pursue this discussion. How do we get more finances? How do we optimize the existing finances? And of course, what model will save the country in terms of reaching out? We have the president putting on the table the NHIF vehicle. How best can we ensure that we support and also put them on toes in terms of monitoring and evaluation, in terms of ensuring that they're doing what is right to ensure that we have value. So for me, I think that's my parting shot. And we still have a journey to work together to stretch the 7% to 15% and ensure that this translates into the results. Thank you.
Thank you very much, Dr. Job Makanga, for that. And I agree with you, we still have a journey to walk. To the participants, thank you very much for attending this session. We've come to the end of our session. We appreciate that you always come back. I'm seeing names that are still familiar from the time we started in March. You're still here with us. Thank you very much. And to the new people who've joined us, karibuni sana. As you've said, public health financing is a political process. Let's not shy off from getting dirty. Let's not shy off from lobbying. Let's not shy off from being political, because that is the only way that we'll be able to get adequate, accessible, affordable care for ourselves and our family members. So I'd like to end this session by thanking all the panelists for finding time. Thank you so much for finding time to come and have this discussion with us. We appreciate you, and we appreciate the energies that you put in. Dr. Victor Njom will reach out to you next time. We also have another one on clinical governance to come and share your insights and wisdom about clinical governance and what you've experienced at KU Teaching and Referral Hospital. And we wish you all the best as you start this journey on a clean slate. It's a wonderful journey, and I think you'll be able to do great. So thank you very much once again. We appreciate you, and we appreciate Dr. John Kinuthia, Dr. Lydia Okutoi, and Dr. Irene Inwani for organizing this session and calling the members together. Asanteni sana. Have a good afternoon, and see you soon.